Go ahead, Angela.
Okay. Pastor Israel, can you go to the next slide for
That one or the next one?
the next one? Not the one that says define prostate cancer. That's the.
Say that again.
It will be the one that says define prostate cancer.
Yeah, that's it. Risk factors. Definition.
Where it says define prostate.
Yeah. Okay, that's it. Prostate cancer defined. Yeah. We're there.
Yeah, she's way up there.
Shortcuts, 90 items, voice guide, off.
Is it on?
Yes.
Okay. Because let's just define cancer. Cancer is an abnormal growth of cells. It can be contained in the area where the abnormal growth of cells occur, or it can spread to other parts of the body. So it's the same thing as prostate cancer. It's a malignant tumor. Malignant tumor means it's something that can do you wrong, something that can do you harm. Benign is something that is there, but it won't do you harm. So malignant is something that can do you harm. It has the potential of killing you. It has the potential of doing damage to you. So that's malignant. So prostate cancer is a malignant tumor of the prostate gland, or carcinoma of the prostate gland. It's an abnormal growth of cells in the prostate. So if you look at the two pictures, the one that said prostate gland, and the one on the left is the normal prostate. So you see where the prostate, there's nothing wrong with it. It's below the bladder, it's wrapped around the urethra. And you look at the other one where it says enlarged. So that's just an enlarged prostate. It means the prostate gland is enlarged. It's almost covering the whole urethra. So that's why a whole lot of men will know when there's something going on with the prostate, because now it's big. It's squeezing your urethra. So when you go to use the restroom, it's hard for you to go, and the flow is very slow, and it comes and goes, and then you think you're done, you go back and lay back in bed, and you get up again. So at that point, most men will know to go seek their primary care physician. That's where primary care physicians are so important in the fight against cancer, because they are 99% of the time, diagnosis of cancer comes from the primary care physicians, because they know exactly what they're looking for, and then they refer them to us in the oncological setting. And then if you look at the normal prostate gland, you see how it looks normal. That's the picture on the right. You look at a prostate gland that has cancer, you see that black tumor on the side. That is still confined to the prostate. It hasn't spread, it hasn't gone anywhere. Next slide, please. Let me know when we get to the next slide.
Which one is that?
It's the one that says epidemiology of prostate cancer in Sub-Saharan Africa.
Yeah, we're there.
Okay, so in Sub-Saharan Africa, men, the most common any type of cancer will be prostate cancer. Over 77,000 men have been diagnosed with prostate cancer. And then after that comes colorectal cancer. But prostate cancer is still the leading incidence of cancer in over 40 countries in Sub-Saharan Africa. And most of the time in Sub-Saharan Africa, when a man is diagnosed with prostate cancer, it's almost at the end stage that you know they have cancer. Because most times they don't seek primary care help. Nobody checks their prostate. Nobody checks for any symptoms of what is happening. So by the time they are diagnosed with prostate cancer, it's almost too late. Prostate cancer really should not kill anybody at an early stage. Most people will have prostate cancer in their 90s and still, run around also like nothing is happening to them. But the reason why it's so deadly in most sub-Saharan African countries, just look and see that we don't have any diagnosis tool to diagnose prostate cancer. And when we diagnose it, the two major intervention for prostate cancer. We don't have them in the country. We don't have anybody that can do a prostatectomy. We don't have any radiation that can cure the disease. So it's really something we have to focus on when we think about it. So it's also mostly diagnosed among men in half of the world's population. So a lot of men will have prostate cancer in their lifetime. Let's go to the next slide, please. So when you look at prostate cancer in sub-Saharan Africa, when you look at all types of cancer in sub-Saharan Africa, prostate cancer is 51.9%. 51,945 people will be diagnosed, which is 20.3%. And then after that is liver cancer. Liver cancer, I think next time we have to do this, I'll talk about liver cancer because of the incidence of hepatitis and cirrhosis, all this alcohol that is being consumed. It's in the end, it's going to damage your liver. All this hepatitis that nobody takes care of or nobody pays attention to, in the end, it's going to turn to liver cancer. So liver cancer is also growing in a lot of the sub-Saharan countries, and the most thing is hepatitis. And then you look at Kaposi sarcoma. Kaposi sarcoma is related to AIDS. So most people that have AIDS, not all of them will end up with Kaposi sarcoma, but most people with AIDS, end-stage AIDS, HIV, will end up with Kaposi sarcoma. And then you have non-Hodgkin's lymphoma, which is also a disease that's related to AIDS. And of course, you have colorectal cancer, and then you have the other types of cancer. But in sub-Saharan Africa, it's prostate cancer for men. So these are the cases in 2020, worldwide, men of all ages. So number one, you see lung cancer in there, and then you see prostate cancer, colorectal cancer, stomach cancer, liver cancer, bladder, and all the other types of cancer. Part of physiology is just the direction the cancer takes, how it starts, where it starts, and how it spread. That's just part of physiology. That's the simplest way I can put it. So prostate cancer occurs when cells in the prostate gland become abnormal. So why do they become abnormal? That is something we don't know. Why do they become abnormal? We know for sure somebody that has a genetic mutation. So somebody that has a family history and there's a gene involved, there's going to be an abnormal growth of cells in those people. Not all of them, but we know if you have the genetic mutation that causes prostate cancer in a family and it's passed on to you, then chances are that is going to happen. Almost all prostate cancer are adenocarcinoma. So adenocarcinoma is just a subset of cancer. So most cancer cells will be adenocarcinoma. You find adenocarcinomas in fluid-making parts of the body, so your digestive system, the lungs, your mucous membrane. So those are all the things that when cancer arises from those areas, we call them adenocarcinoma. So that would be the lung, the breast, the prostate, the colon, the stomach, all those are adenocarcinoma. And then you have the neuroendocrine tumor. So neuroendocrine tumor of the prostate will be a different mechanism than adenocarcinoma. And then you have the transitional cell carcinomas, and then you have the sarcomas. Sarcomas will be very difficult to treat. They're treatable, but they're just hard to treat. So what are the risk factors? So this is what puts you at risk for say, okay, am I going to get prostate cancer? Is this going to happen to me? So 1 in 7 men will develop prostate cancer. So just look in the room and start counting 1 in 7. In breast cancer, we say 1 in 8. In prostate cancer, it's 1 in 7. So age, 60% of prostate cancer will be over the age of 65. So when you above the age of 65, the chance of getting prostate cancer is not 60%. Does it happen in people that are less than 65? It does happen. And most of the time, when you look at people that are less than 65, check their genetic makeup. Because most of the time, they have that BRCA genetic makeup. So 65. So the older you get, if you do a biopsy today let's say you go to Connaught, you find 10 people that are dead, men that are dead, that are in their 90s, and you do a prostate cancer of the gland, chances are they have a small prostate cancer. It's a slow-growing cancer. Okay, so race, ethnicity, so Black men. We used to call this prostate cancer in men of West African origin. It is high in Black men, even in the United States, and it is high in Black men around the world. For some reason, that is something we just don't know why, but it's a disease of Black men. And Black men, African American men, are 64% likely to get prostate cancer in their lifetime. So family history. When your dad has prostate cancer, your brother has prostate cancer, the chances of you as a son getting prostate cancer is high. The gene, I talked about the gene, the breast cancer gene, so the BRCA. So if you have, a mom has breast cancer, dad had pancreatic cancer, another brother has prostate cancer, or sister has pancreatic cancer, check for the genetic mutation. I just met a man this Saturday who lost his dad to prostate cancer, lost his younger brother to pancreatic cancer, lost another brother to prostate cancer. He was so depressed. So I told him, I said, go see your primary care physician and talk about genetic assessment and see if there's a gene in the family that's causing these various types of cancer, because chances are there is. So a diet, a decreased level of vitamin D, which we should not have in sub-Saharan Africa because the sun gives us vitamin D a lot. So most people in sub-Saharan Africa don't even take vitamin D. It's not something that's marketed there. I wish it could, because maybe it will help if you don't get it enough. So prostatitis. Prostatitis is just inflammation of the prostate gland. If you keep getting repeated prostatitis, talk to your primary care physician and let them just do some blood work, the PSA, and see if it's elevated. Of course, chemical exposure, you find this in people that are exposed chemically. So every time we have anything that's a chemical exposure anywhere in the world, you will see an increased incidence of prostate cancer. Of course, increased level of testosterone. Testosterone is the male hormone. Well, increased level of testosterone, it's good for men, but it also feeds the prostate gland, which can sometimes develop prostate cancer. So next slide, please. So the next one is clinical presentation. So are you guys hearing me? Mm-hmm. Yeah, okay. Yeah. So the next one is clinical manifestation. So usually this is this is what you see. This is a phenotype. This is what you see, or this is what your primary care physician sees. This is what you see. Let's go talk to primary care physician. Like I said, I emphasize primary care physician a lot because they find all of these and then send them to also medical oncologists. So slow urinary stream. So you got to go use the bathroom at night. It's coming out so slow. Instead of taking 2 minutes, you're taking it 10 minutes, but it's coming so slow. That's one thing. Hesitancy. You think you want to go, but when you go, nothing comes out. So you begin to imagine, well, last year at this time, this was not happening. Incomplete emptying. You go use the bathroom. You think you've done. You go back to bed. 10 minutes after that, you want to go again. So these are the things that begin to clue you in that I need to see somebody to check me to see what else is going on. And of course, waking up too many times at night to go pee. Swelling in the legs. Swelling in the legs, if you already have swelling in the legs, chances are your prostate cancer has spread towards the lymph nodes. Because swelling in the left is blocking. It's because the lymph nodes that feed those areas, that drain those areas, are now being blocked by maybe the cancer itself. Okay, enlarged lymph nodes. Because if you feel under your belly, your inguinal area, if there is anything in there that is affected from the prostate, you feel those lymph nodes in there. Mental confusion. Mental confusion just means it's too late. Your prostate has already spread to the brain, so you can get that. Bowel obstruction, it has spread to some area where it's obstructing your bowel. ED or impotence. I mean, you can still get that without even prostate cancer, but that's how most people say, let me do something, because now I'm not functioning like I used to do. Bone pain, it means the prostate cancer has spread to the bones, which most prostate cancer, when they spread, the first area they spread to most times is to the bones. So how you diagnose it? So you go see your primary care physician. Dr. Pia, Dr. Sharif, this is what's happening to me. And Dr. Sharif will say, okay, Dr. Pia will say, let's do a medical history, a thorough medical history. it is the backbone of every diagnosis in anything, not just cancer, in anything. The thorough medical physical exam. You cannot things. You have to really put your hands on the patient. You have to listen to them, let them tell you the symptoms, engage them, ask them open-ended question, let them tell. And then you do a blood work. PSA is a prostate-specific. It's a blood work which to see how what are your level of prostate, what are the level of so in men body in the United States, and I think it could be around the world, you start getting PSA at the age of 40. If you have a family history, your dad, your brother was diagnosed, try to get earlier than that. So anything less than 2.5 is not technically normal. It's normal in somebody that has not had prostate cancer. Once you have prostate cancer, less than 2.5 is high because if you've been treated for prostate cancer, less than 2.5 is detectable. Normally, when they do, I've been treated. 4.00 something. But if you don't have prostate cancer, less than 2.5 is normal. And normal is more than 4 nanogram per millimeter. So DRE, so that's digital rectal exam. Digital rectal exam, I mean, everybody that's trained, or everybody that's in the rectal exam, is just putting your hands, your index finger, you let the patient lay back, bow down, and you put your gloves on, and with KY gel, and you put your hand in the prostate and feel it at the bottom. And then you check, is it swollen? Is there any knots, edges around the gland? Something going on. And that's something you can do. Already. Embarrassed, they just want to. But it's a way that they can help. And then, of course, there's biopsy. The biopsy is just all of the problem. Normally, they do talk 12 because you have to do every area so you don't miss anything. So they do a biopsy to make sure what is going on in the prostate. And then, of course, there is a Gleason score. The Gleason score, it just tells you how abnormal your prostate cancer is when they got it and looked at it under the microscope. So anything, it's a grade 2 to 4, it's less aggressive. Those people tend to do well. 7 to 10 is very aggressive. It doesn't tend not to do very well, but you can still do well. Of course, 5 to 6 is in the middle. So 5 to 6, they decide, okay, follow you, do we do surgery, do we do radiation, what do we do? Most of the time, 2 to 4, less aggressive. Those, okay, let's just do maybe every 3 months for blood work and scans. 7 to 10 is very aggressive. You're going to have to do surgery, radiation, something to take care of it. Okay, so I have to speed up. So diagnosis also include the genetic testing that I talked about. You have an MRI that you do, MRI of the abdomen on the prostate to see if there's anything going on in those lymph nodes. It's a PET-CT scan. PET-CT scan just check the whole body to see if this cancer is anywhere else other than the prostate area. And of course, the bone scan, because most prostate cancer is the bone. So we have to do a bone scan to make sure it's okay. So how do we treat prostate cancer? One is observation. So men in their 80s and 90s, if you have prostate cancer and it's low growing and the Gleason score is very low, most of the time they don't do anything. They just monitor you because you're 90. How many more years would you live anyway for you to undergo radiation, undergo surgery? So they just so surgery is where you have to start. Okay, this is fast growing, or it's slow growing. My Gleason score is maybe in the middle, but I'm a young man. I'm in my 40s or 50s or early 60s. I can live 20, 30 more years, and I don't want this thing to come back very soon. So then you decide whether you do surgery. You could do surgery, which is most of the time now in the United States, it's a robotic surgery that they do. We have it here in the practice where I work. It's most institutions now have robotic surgery where they go in and they take the prostate. It's just removing the prostate gland. So once you remove the prostate gland, now you have to think, if you are at a childbearing age and you think you want to have kids, then don't remove the prostate. Because once you remove that, you're not going to have any more babies. You're not going to make any more babies because the sperm, all of that goes away. But there are side effects to all of these things. There's erectile dysfunction that comes with it, but now it's manageable by doing other types of surgery. There's incontinence. So they always tell you lose weight before you have your surgery. Do the Kegel exercises before and after your surgery to help with incontinence. Most men will never have incontinence because they take care of that. And then, of course, there's radiation. So there's the external beam radiation. Most men with prostate cancer, most men would undergo radiation therapy. But radiation can buy you a long time or it can buy you a shorter time. So it depends on where the prostate is, how many glands were involved in this thing. So people will do radiation surgery. And then, because most of the radiation surgery is what we call external beam. So external beam is outside that they do it. So internal beam radiation or brachytherapy, where they go inside and plant some seeds in there and do radiation inside. They all have consequences. They all have the effects of the ED, which is erectile dysfunction. They all have the incidence of incontinence. And radiation therapy sometimes, when it's close to the rectum, it can cause pain when you defecate. So all of those things, but they are all manageable. Yeah, it's things people do to live. So, but all. And then there's cryotherapy, which is just freezing of the prostate itself. They're going in to freeze the prostate. There's hormonal therapy, which is the androgen. You give yourself injection. That's in combination with radiation therapy. So you give yourself the hormone injection. It's either once a month or every 3 months. And it causes a lot of things. It causes these hot flashes. It causes some depression in men. It causes this other thing, but most men will tolerate it for 1 to 2 years and you're done with it and you go back and live your life. And then, of course, there's chemotherapy. Chemotherapy is normally for late prostate cancer or stage 4. So that's prostate cancer that has spread to the bones, the liver, the lung, or somewhere. Most men, when they're diagnosed, there's no chemotherapy involved. If you are diagnosed today with prostate cancer and you have to do chemo, that means it has spread. That means you've had that prostate cancer for over 10 years without even knowing about it. Now you already need chemo. So chemotherapy is for late stage prostate cancer or stage 4 prostate cancer, and there are a lot of chemotherapy they do. I always say here that in the United States, there's so much bias towards men because a lot of research is going on in prostate cancer. There are a lot of drugs involved in prostate cancer. We women for breast cancer have to fight all the time to get clinical trials, to get research. Men have a whole lot. And because a whole lot of men in the United States have prostate cancer. There's a lot of funding and research going on. So it's just my bias. So there are other types of treatment. There's immunotherapy, which now we have. Keytruda is a life-saving drug. It's been used in a whole lot of settings. We use it in breast cancer. We use it in GYN cancer. It's used in lung cancer. It's used in prostate cancer. It's used in bladder cancer. It's used in a whole lot of things. So maybe the future of cancer and chemotherapy will be immunotherapy. And of course, there are the pills that you can use. There are some pills, if you have the genetic makeup, like the BRCA1 or BRCA2, there are pills they can put you on to take, just in case you don't want to do the chemotherapy. And of course, there's a cancer vaccine that's ongoing, where they take your blood cells, take it to a lab, refine it, and bring it back and infuse it into your system. So in a nutshell, next time I think I'll do a specific thing about prostate cancer. But in a nutshell, that's it about prostate cancer. So my advice is it's really difficult for us to do a mission trip based on for cancer, because when you go there, you diagnose somebody prostate cancer. What do you do for those people? And these are for the medical professionals in the audience, people in the ministry. If I take a team, because every time they ask me, can we do a mission trip there for that? No, we cannot, because if you go, we diagnose somebody with prostate cancer. What's next? What do we do? So this is my presentation. Thank you.
Thank you. Thank you, Dr. Dubia. Thank you. Can you hear us?
Yes, I can hear
Thank you.
Thank you. You're welcome. If there are any questions I can answer, I'm here for.
Question. Maybe you can advise.
Yes, Dr. Dumbuya, what would you
the average African man about DRG?
Digital
Digital rectal exam. Yes.
exam. I don't even think.
No, these African men still want to be examined rectally. It's not culturally sensitive.
Yeah.
So how do you tell your husbands and your brothers that it's important for them to get a rectal exam?
Okay, so normally it's not just men, it's even men here. We have many that take a lot of them when they come in, if they see a female, chances are they're like that's a shame they will let them do it. So most if for men, really we have to train men physicians to do it. Because I mean, I can do it. Yeah, sometimes we come, I will do it. But it's really the men that they feel, okay, I can go to this man and let him examine my prostate. So we need to train men physicians to know to do DRE. They will do it for a man. It turns that they may not do it for us. But then again, I tell the men that come in here, if I go to my primary care, my OB/GYN, and lay there and let them put a speculum and examine me, don't you think it's embarrassing? It is, but it's for my health. So it's the same for you. Go there, bow down. It doesn't even take 5 minutes to do a DRE. But to me, I think we need to train more men physicians in the continent to do it because they'll open up. They'll be able to. They want to do it. But for a female physician, it's gonna be hard. That's just what I think.
Thank you. Anyone have any other questions? One more question.
Yeah.
Yes, sir. Cancer is really debilitating. Is there any treatment for it, or have you discovered any latest treatment for it now? And what's the name? Because they tell us, you people in the US, when the baby is small, they start giving her an injection that will suppress the cancer in their body. Is there any treatment? Any latest?
Thank you. So I'm not sure.
So what question is there any treatment for cancer? Is that the question?
Yes.
Yes. Oh, yes. There are lots of treatments that are available now for cancer. There are a lot of treatments that cure your cancer. If it comes back, that's a different thing because everything in life may or may not come back. But there are cancer today, even prostate cancer. Surgery cures it. Whether it comes back 10 years from now, it's different because you can have diabetes that you never cure, but you always taking medicine for it. There's cure for breast cancer. There's cure for colon cancer. There's even cure for lung cancer. But that doesn't mean 10 years from now or 20 years from now, it's not going to come back. It may or may not come back. But the question about they are giving babies injections to cure the cancer, no, that's not true. That doesn't happen.
Thank you so much.
Well, actually, there's a vaccine for young girls, which can prevent cancer of the cervix.
Yes.
Because what happened is HPV. Because what happened, there's a particular virus, virus, which is one of the commonest causes of cancer of the cervix. So the opinion is that since it is the most common cause of cancer of the cervix, if it's prevented, most likely cancer of the cervix will be prevented.
Yeah,
Thank you.
Dr. Sano,
last answer question here.
Let me say something, Dr. Sano. Let me just add something to that, what you said. So the HPV vaccine is not really just for girls, because HPV can also cause head and neck cancer, throat cancer, cancer of the head and neck area. So HPV, the vaccine is really for boys and girls in puberty. So it's really encouraging to give those to them. Because we see in our head and neck departments here in where I work at, we see people that come in that have head and neck cancer. So head and neck cancer will be the throat, the mouth, the tongue, the all those areas, the sinuses that HPV contributed to. So HPV vaccine is good for boys and girls in the younger age. It prevents cervical cancer, but it also prevents head and neck cancer in both sexes, men and women. So it's really for men and women that should have it.
Yeah. Good afternoon again, everyone. So this is not really a question. I just want to elaborate on something very quickly that she had said. Because what happened is that I know she mentioned that we cured some of these cancers, but it's very important the stage at which these cancers were diagnosed, and then that determines whether or not it's going to be curative, and as well as the prognosis. So it makes it even more important that we do the screening, that people actually come and then we screen them so that we'll be able to get this at the earlier stages and then and treat them accordingly.
And that is so
Thank you. So now we're gonna go.
so
Thank you so much, Angela. Go ahead.
You're welcome. No, I said I was saying that the last lady that just said the stage at which scale. So early detection saves lives, because your cancer cannot be cured at stage 4. No, nobody's cancer is cured at stage 4. I mean, you can live a long time, but you always have cancer. Stage 1, 2, and 3. Even stage 3, where it's a higher stage, it can be cured. Stage 1 can be cured, 2 can be cured, 3 can be cured. But stage 4, on and off for the rest of your life, you're going to be on some form of therapy. Whether you take a break or not, you're going to be on some form of therapy. So that's why screening is really, really very, very important. It's not just because, okay, we want to find it out. But if we find it out very early, then your chances of a cure becomes greater.
Okay. One more. Our minister here has something to share.
Thank you very much for the good presentation. And I think as a Minister of Health, we continue to have in-country capabilities. I'm sure we have a postgraduate college of health sciences. The surgical unit is being accredited department, and we have consultants and urologists in country, TB camera. The younger generation, they are actually on top of situation in terms of a lot of these things in the country. Prostatectomy is being done, and there are a lot of other ancillary tests that can be done. Our histopathology unit at Connors Hospitals is way, way good for biopsies and examinations of such. Few weeks ago, we had a case of liposarcoma. Unfortunately, it was stage 4, but it was well diagnosed there. So no doubt we have developed the in-country capabilities. Maybe I will say more about that. So I think as a country, we are advancing the human resource capacity. I'm proud to say that. I'm sure we get on top of this in the coming years. Thank you.
Thank you.
Thank you. So, Angela, just to add to what the minister has talked about, I think primary care assessment is the key. Prevention, that's the key. For advanced countries with all the money, with all the technology they have, when you have under-resourced countries, if you know you don't have the money, you have to put all your energy in primary care, because if they catch you in stage 1, you can cure it. But if the only time the doctor sees you when you have stage 3 and 4, and in most cases in Sierra Leone, from my experience, that's what happens here. And at that time, some of the medications are not readily available in Sierra Leone. And but if we really do better with primary care, some of the things that the minister talked about could be addressed. They could do the surgery, they could do the biopsy, but we have to increase primary care assessment. The men, especially men over 65, need to have their prostate exam or even their PSA. And that will really go a long way. That's what we need to do better. I mean, even in advanced countries, preventive health is the key. I mean, you can't put resources is unlimited. So your preventive care is the key.
Yeah, that's true, Dr. Sherry. That's true.
So we're going to go down to the panel. We're going to have inputs in respect to going back to our chronic disease as well as addiction. And then after that, we'll have a Q&A. Let me start with Dr. Bell here. So just to kind of elaborate to some of the social impact or something you talked about on your for that percentage of Okada addicted to substance abuse. I mean, that's a huge problem. I mean, you can imagine these people are riding people all over the place, right? Increases accidents, increases death from accidents, and that's such a huge problem that we need to address.
Yes, you're absolutely correct. That's just one of thousands and 10,000s of problems with this substance abuse. I mentioned the medical students who dropped out. you know, there are other students who have gone down the drain even without us knowing. Now, one of the main issues is first recognizing the problem. But then when we do recognize the problem is actually where they're going to go, where they're going to be managed. So with substance abuse, it's an inpatient management, and after that, on an outpatient basis, they have to then continue. So it's a long-term management. So the question is, where do they go? That's one of the main issues. I saw one statistics that said that only 11% of those people with substance abuse and mental health issues can be catered for in Sierra Leone. So that's a small number, and we should try and see how we can manage this situation when first get it recognized, and then how do we manage these individuals holistically and properly.
I mean, obviously, prevention is another key here. Everything in mental health, chronic disease prevention is key. Anything you have to add?
Well, basically, reducing the stigma, making sure that you accept the individual. They are human, and it's not sometimes their fault the way they are. So we need to accept them and try to understand. And also the schools, we need to educate the school system. We need to have a place where students can go and, you know, distress or whatever they are dealing with. They came to school, they're not able to function. We need to have that type of infrastructure so students can go there and just sit down and just voice whatever is going on through their lives. And also educating the village people. I mean, sometimes we hear, oh, well, because you don't have anything better to do, that's why you're depressed. We hear a lot of that, you know, parents from here, when their students, I mean, their children, Daddy, I'm depressed. They will say, well, because you don't have anything to worry about. You don't have a house to build back home. But they are really worried, you know, they already have their own property they're dealing with. So we really need to train our individuals, our parents here, to listen to our kids, listen to them, what they're saying. We need to make sure that, you know, we accept what the problem is and try to help them solve it. So that's what I have to add.
Thank you. And another thing, probably a segue, me personally, as a family person, it's the issue with addiction to social media with kids, with mental health. I mean, I have 2 young kids. One of the things we delayed them having phone and social media probably when they're like 12 or 13. It's a huge problem now, obviously. Social media, addiction to social media, and all this other stuff. There was a case recently out in Nigeria. There's a young man who was in communication with another young girl somewhere in the U.S. They having some, they share some pictures, and this young man tried to ask the girl for money if she doesn't give her money, and he posted some of the private pictures that she had shared with him, and the girl ended up went and killed herself. So the U.S. went all the way out spoke to the Nigerian government. That kid was extradited from Nigeria to the U.S. just to go to court. I mean, so the world is changing when you have young kids exposing to all the social media and all the stuff. That's not a big issue that we have to deal with. Doc, any concern on that?
Yeah, thank you very much. That's a very big issue. And as I mentioned earlier on, in our society, you can see the peculiarity that peer pressure among our school-going children, among our university kids, is a very big problem. You know, and as an association, I'm happy I have this platform. What we are doing now for substance abuse is to target school-going children and university children, because we realize that they are the most vulnerable group. So I'll be happy if Healthcare USA Sierra Leone can support that project. Firstly, we are having an ongoing survey to find out, you know, the impact of substance abuse among school children. And when we want to have that data, we use it as an informed, you know, opportunity to make certain choices in reducing the burden of substance abuse. One of the things we intend to do is to have training sessions for school children about the influence of social media, how to recognize, you know, substance abuse among peers, how to resist peer pressure, you know, and we also want to train school teachers, you know, college lecturers in terms of how to recognize and support victims of substance abuse. So it's a huge problem. It's multifaceted, and I'm happy we're having this symposium. And I'm really looking forward to collaborating with Healthcare Salon USA to see how we can reduce the impact of substance abuse among our school-going children.
I mean, that's a great one. I'm not sure if hate to put the minister on the spot. Obviously, I think that's definitely a good thing to have funding for, to start doing some of this research, to start addressing some of this early interventions. I'm not sure the minister can add.
Thank you very much. I think we work very well with allied associations such as the SLMDA, because they are there to complement our efforts. And we work very well with the development partners, because if we all synergize our efforts, we can maximize our output in substance abuse and chronic diseases. Well, having said that, we have a bigger platform at the Ministry of Health, actually in terms of the healthcare delivery, especially in chronic diseases and substance abuse. Our model is built on the life stage model, which means from conception to senior citizen, we look at all the factors that affect the patient in that journey of life, including malignant diseases, including substance of abuse, etc. Just a week ago, I was down in this hall. We launched the National Research on Cancer in Sierra Leone, and we have almost finished the strategic plan for non-communicable disease in Sierra Leone, including cancers. So as a Minister of Health, we're very ambitious with what we are doing. And then based on that life stage model, we look at healthcare again from what Dr. Fuad Sharif said. For models, the primary healthcare is almost 80% of our investment. Then we have the secondary and tertiary care, which we are working very hard when the patients finally land in the hospitals. And in between, we have the referral systems, the mobile clinics, ambulances, the chief is just working in. And then we have the health security. And there is deliberation in what the government did to land the issue of substance abuse in the National Public Health Agency, because pandemics begin and end in the communities. So there is a direct correlation between pandemic and primary healthcare, and we're working on that very much. Also, in the area of chronic diseases and substance abuse, we have access to health facilities within a 3 to 5 kilometer radius, which is very important to make sure that people have access to care and also to information. There is a special line dedicated for mental health issues, 5116, and the 117 issue. So as a government, we're working very deliberately to that. Also improve the quality of care, especially in substance abuse and chronic diseases. We have the model of improved the quality of care. 4 main domains: infrastructure development. We need infrastructure fit for purpose, like our colleagues have said, to make sure that people are able to have fit for purpose infrastructure. Aligned with that, also, we have solarized our facilities to also we have renewable energy all over the country to make sure that we can build upon that to have data for research purposes and for healthcare planning in the future. And we are very deliberate in making sure the laws of this country also align us, especially for chronic substances and the push epidemic. We have revamped the 2001 pharmaceutical law, which is not fit for purpose. Now we have actually have the 2024 law that actually diverts its product for the professionals. And in the product, for the first time ever, we are regulating substances which are used to make push. That's very deliberate. We tighten the tap upstream, and also for even the caustic soda and others. So we are really working around the clock to make sure that we have a plan for this country, because if you don't have a plan, the development partner will give you one. And secondly, also the human resources is something very critical to us to make sure that we train our staff. I was talking about Connaught Hospital, the capability not to diagnose cancers in this country based on the national strategic plan. And we are very deliberate in that also. We have the Postgraduate College of Health Sciences. We are working around the clock. I think our first graduates from obstetrics and gynecology, 100% pass rates, Dr. Delibel, your neighbors. And the pediatrics to be accredited. Also, we have the surgery and medicine. So we are really advancing human resource. Along with that is what is music to the ears of my able president, welfare of our healthcare professionals. The nurses were given more pin codes than any government in the history in 1 year alone. And we're marching towards that. Continuous medical education, continuous professional development is also on the rise to make sure that we have adequate. I'm so proud of Dr. Lelibel presenting with data, with everything we can stand upon. We are believing the capacity of this country much to what we had before Athens of West Africa in education. And not only that, we have other areas of diagnostics, which I will not delve into it. So as a government, we are very much focused in other thematic areas. the substance of the push epidemic, I mentioned the Minister of Social Welfare represented Mr. Corden here. They developed a unique model, that family-centered care in their home, that has helped to really revamp and turn around the case of push patients. Patients of substance abuse that they have treated in London, in Ghana, and everywhere, they came to Sierra Leone, they were able to get that cure they needed. We need more resources, human material and financial, like any third world country, to be 100% on top of the situation. Of course, the internet and all that is all fall in line with what we are doing in human capacity development. I thank you.
Thank you so much for that. So, Dr. Suleiman, what do you have to add to this conversation in respect to, obviously, chronic disease as well as addiction?
I think I would switch the gear a little bit. As a neonatologist who deal with very sick babies, I know over the years, Sierra has a bunch of SCBUs, second baby nurseries, where the babies can be revived and go and basically go through this nurseries. But then afterward, for those babies who will have, as we see, some of them will have cerebral palsy. And I've come across some of them, and once in a place in Royal America, when we were faced with a baby who actually was having some, not like maybe has some HIE and actually has cerebral palsy. So almost 5 years old, cannot sit down, cannot walk, doesn't have anything to do for himself, was purely dependent on the grandma. So if you go around the country, all the SCBUs and all these cases of babies who have asphyxia, who are revived and come to these SCBUs and to survive, what's the long-term plan? Now, in advanced form, you have to every advanced SCBU, living in particular parameter or locality, you have a developmental pediatrician, you have social, you have OTPT, occupational therapy and physical therapy people who are able to help these kids to develop their different skills. So to the minister and to Dr. Bell, I think this is an area they also have to invest in. I don't know why they have any facility for those, because clearly otherwise this will be people who will grow up to be wholly dependent on the system. And in advanced countries, some of these babies, if they survive because of those facilities they have to serve them, occupational therapy, physical therapy, developmental pediatrician, where they're able to see the deficiencies earlier in their growth or in development, and they're able to address because they have areas to address them. I want to know whether is there any plan for those babies in the future in the country, and what's to be done. But clearly, I'm sure with a bunch of SCBUs in the country, almost in every district, as I'm being told, I think it's good then that there should be programs like those in place so that these students could be addressed very early in their development. Over.
Thank you so much, Dr. Sano. So obviously, I recall Dr. Freddy Coco talked about the non-communicable disease clinic in Pujan Hospital. I'm not sure if that's the only place that's doing that has a clinic specific for non-communicable disease. I think we need to have more of that stuff within the country. Dr. Pierre?
Yeah, just to add a few things to what we've said. I mean, we have a lot of data coming up from the ministry that we've done this, we've done that. Let me ask a little question. How many of you have more than 40 years of age? How many of you here have had a blood test this year? How many of you here have had a blood test last 2 years? Last 2 years. How many of you women, what are 40, have had a mammogram? You see the number? So we are not doing well. When we talk about preventive care, and this is what we think we should focus on to prevent these complications that we have. I mean, if we are talking all of these sort of things, we cannot encourage our people licenses have done a form of care. So I think we're not doing a good job. But yet still, we have room to grow. Basic preventive care is going to save a lot more ground when they are 40. They should have a colonoscopy done. We can treat these diseases. No, not to bring all this up. And I'm sorry to say this, but even in America, we cannot provide adequate curative medicine. We're not able to do that. Sierra Leone has 7.8 million people. We should encourage our government, our practitioners, to focus on these preventive issues. You know, it is not only a medical issue, it's a social and economic issue. If we don't do this, we're going to lose our population. Thank you.
Again, thank you so much. There's one thing that I know certainly very well. Pediatric immunization stuff they do with the kids with immunization. One of the other big thing that we probably have to do better is immunization of hepatitis for hepatitis B. Because in the next 10 years in Sub-Saharan Africa, Australia included, most of the cancers you see is going to be from liver cancer because of hepatitis. And if you have immunization for hepatitis, it's preventable. So at Connaught, you don't have too many people that's immunized with hepatitis. Like when I was a medical student, before you go your hospital immunization, you will not even go to the hospital. You will never enter the hospital. I don't care which rotation you're on, who you are. If you don't bring your immunization, you will not do your clinical rotations. And we need to improve the immunization record for adults for hepatitis B, because the biggest issue is going to be liver cancer. All of the deaths, liver cancer from hepatitis, and the vaccines are there and it's cheap. So we have to do better in Sierra Leone regarding immunization for hepatitis.
Yes, so I can address that in terms of the pediatric population. So now we have embedded in the 6 weeks, 10 weeks, 14 weeks vaccinations, hepatitis B as part of the pentavalent vaccine. And now the government, the ministry has just started to roll out hepatitis B vaccine at birth, which is what happens, which is the WHO recommendation and happens elsewhere. So, so for the kids, and this, I'm not too sure exactly when we started doing this EPI program for immunization, but I think 10 to 15 years maybe ago. So those 10 to 15-year-olds don't really need, they're all covered with hepatitis, or they all got immunized at 6 weeks, 10 weeks, and 14 weeks. And the rate of immunization is actually really high in Sierra Leone. So that's at least one good news. There were many good news, but that one is positive about Sierra Leone. I just wanted to address Dr. Sano's concern in terms of the management and the follow-up of these babies that are coming from this, or being discharged from the special care baby unit. So that's different from the NCD clinic in Pujol. So what we're trying to do, and Dr. Coker is also part of the department, we're trying to have outpatient, specialist outpatient clinics. Okay, so these kids now come, that's why I mentioned before, every Tuesday, we have a lot of babies, so they come up for follow-up. And when they pass the neonatal age, and when they pass the age where the neonatologists see them, we pass them on to the pediatric neurologist. So we also have a pediatric neurologist in the specialist outpatient clinic that sees these kids, that will come up with CP. But having said that, that's just in Freetown for now. So we're working together, the Pediatric Association is working together with the Child Health Program at the Ministry of Health to roll out a whole lot of these pilots that we have done in Freetown, to roll it out for the rest of the country. We just sent one senior resident, one of the cohorts that have become a pediatrician through our program. He's just gone up to McKinney to start working with the pediatric department and the specialist, in McKinney, to work with SOPs, to get some guidelines, to teach and to do clinical work in McKinney as well. And he will then set up that kind of clinic in McKinney. So that's the idea, train them and then send them up so that they can do quality healthcare. Thank you.
Thank you so much. I mean, one thing I can really attest to, something that's really last 10 years, is pediatric immunization. There was a time, a couple of years back, a physician had seen, I believe, a 12-year-old kid before they need to endorse their paperwork to start school. And I happened to know him, and he was like, oh, I saw a child, 12-year-old, starting school in the school system. I was really impressed they have an up-to-date immunization from Sierra Leone. I said, well, these are one of the few things we're getting right. They have the immunizations for the kids. Now, the adults, right? The people who are in their 30s, 40s, and 50s who are working in other hospitals who don't have some of this immunization that needed. That's important. So let's do a Q&A now. We're in the Q&A section. Except any of you guys have anything to add?
Yes, I mean, on behalf of our organization here, I would really actually encourage the Ministry of Health and all of our practitioners, like we are talking about immunizations and things like that. Look, 2 weeks ago, last month, I did not complete my influenza, my flu vaccine. I was stopped to see patients in the hospital. And you can't get annoyed with that. But what I think you should encourage here is, like all the young girls who sit here, we say we are having all these things. Let us have a clinic where they can go at least their pap smears. We can decrease endometrial cancer. Let us have a clinic where people can have all these immunizations. I will help my group here to try to get some vaccines here. But if these things are not in place, we cannot help. You should ask for this. We should stop asking for big old things to be done in this country, while we should do the basic little things to improve the health system. That's my plea to the Ministry of Health and the government. Okay. Thank you.
Thank you so much. The minister wants to respond. Which you don't get 20 now. You don't get 20.
I think what I like of Dr. Pierre that we rhyme a lot in thoughts. We think a lot, and what he said is also being implemented. To see, we have the Child Care Act of 2022, which encompasses most of this. We have policies in reproductive and maternal health, which encompasses this. And we are also looking for innovations every now and then. And we are the sort of ministry where we don't rest on our hours. Each one of the doctors sitting here will look at innovative ways of improving healthcare system. And along the company, I see we have a colleague here, Emmanuel, understand of. I invited him to Sierra Leone. I work with him in the global stage. He's one of the biggest gurus in artificial intelligence and innovative ways of doing things. And he's here with 5 big projects. One is our vaccination. Sierra Leone, we have the EPI program, and it's unique in that all vaccines for children go through the EPI program, one platform. Quite unlike other countries where malaria does their thing, these to do their things. So we are really working on that. That's, of course, well effectiveness, and he's working with the EPI to make sure that there is an alert system with SerraVax. It's a tool which captures the data real time and feed it in the DHIS. So that's very deliberate in one of that innovation in vaccine and malnutrition. That's what he's developed the app that we're going to roll out in Sierra Leone. And there's a lot of other things that innovative ways. For instance, solar energy is one we want to utilize for our maternal and child health. Where we are going maternal mortality will have done extremely well. We used to be 1,500 per 100,000 life, but right now we're about 300 per 100,000 life. But I want to improve more. One of the greatest challenges we have is the riverine areas. Our ambulances cannot access the riverine areas because we don't have the fear to maintain them. But Emmanuel and his team, so what I have a concept, they've now developed a solar-powered boat hybrid system that uses solar and energy to make sure that at least 20% of our hospital budget is on solar energy. We will be the first one in Africa, by the way, to land that, and he said we should patent it. We keep thinking out of the box every now and then to complement the effort of the healthcare delivery system, and there's more and more and more to come. That solar ambulance is not only for the riverine areas, but the pediatric hospital, that ambulance standing there. In the UK, in the metropolitan area, it's something we have got. It's going to be a reality.
Thank you. Emmanuel, don't just stand there for a second here. I know some of the biggest issue we have not done too well in Sierra Leone is to empower the youth. I mean, there's a lot of smart young people in this country, but we just don't have the resources to empower them. Here's an example. So while you're here, what can the minister or the ministry or the government do to empower you to do better? And don't be afraid. If anything happens, I'll take care of it. Don't be afraid. Say exactly what you feel.
Thank you so much. Thank you, Honorable Minister and the Chairman. So my name is Emmanuel Sechanze. I'm from Uganda. Yeah, so I'm happy to be here. And I'm always happy to engage with the diaspora because I've spent 5 years of my medicine in India. So I have anesthesia and critical care, then master's in medical informatics and AI. So I'm back, and whenever I see other people back, I feel motivated to work more. So I think when it comes to the youth, I'm a believer and a Christian. I always tell myself the Bible says that knock until the door is open. So sometimes we are going to face challenges to knock, but we cannot stop. So me, I don't call upon leadership every time. My question is, as the youth today, are we having the courage to take on from our forefathers? Because I feel like we are becoming weak. Because some of my fellow youth, you are rejected at a job place, you are rejected in one office, and you want to commit suicide. And we have our fathers that we are celebrating today that fought in World War, our mothers that carried guns to liberate this country. So I think a question goes to the youth whether we have the courage to take over from our forefathers. The next thing I think is, I don't call the leadership to involve us in the lead. I call upon them to build the systems and the infrastructure where we can take over from. My only challenge is every time we come back to the continent, we have to start from zero. And for the last 5 years I've spent in India, you start somewhere at least. If you build an app in India, you can host it in one night because they have the cloud-based servers built. Now we are talking to a country like Mama Salon where we don't have the cloud servers available. So the question for me is, how best can we have those infrastructures and the basic ones started? And I'm a premature baby. My mother was a teacher. She lost my pregnancy when it was 7 months. I was in incubator for 42 days. Till now, when I go back to Uganda, the same village, there's no incubator. And so it's the same thing. What I say, it's more of systems and infrastructure than what the youth we are focusing on, which is, I want to be in a position, I want to be here, I want to be there. Make the systems right for us. Lastly, when I talk about system, the example I can give you is the innovation of the youths. The Indian system has been changed to innovation education, where they have incubator centers for student ideas from primary level, secondary level, at every chiefdom, and then at the national level, you access funds and support. Such a system we need. The rest we will navigate. We are very powerful, we are African, and we love our countries.
Thank you. I'm glad, interestingly, you said you're from Uganda. Maybe 2 years ago, I was actually in Kampala. I was at the airport in Kampala. I was in Kampala for about a couple of days. And on my way back, going back to the US, I saw lots of people at the airport, young people in their 20s. I thought they were going to India or the Middle East to study and all this stuff. All these people are on there to work in domestic work. These are the brilliant minds in the country. They're all going to these countries, UAE, Dubai, to work. I mean, that broke my heart. I thought they were like on vacation. They go to colleges and stuff. 90% of these people are going to go do domestic work. And these are the most talented, smart people. We're sending them to the Middle East to go do domestic work. That really broke my heart when I saw that. By the way, I love Kampala. Kampala reminds me of Freetown in the 80s when I was a child. Freetown, they still have their stuff together. Bata is still there. I don't know if you know Bata. I was quite surprised. I actually went into the store. I took pictures because when I was a young man, when you were in primary school, you went to Bata to get everything, your raincoats, your school uniforms, and everything else. So when I saw Bata and Kampala, I was quite excited to see that.
I think Now, this is interesting because this is the current research I was speaking. When I went to South Africa, where I was just awarded African Future Shaper, I was speaking about the same thing. My current research shows that 3 in 5 African young men want to leave the continent. And the current research that was done was saying that 58% of us want to run away. I don't know where we want to go. But the question again lies in the leadership. I don't talk about leadership most of the times at the top. I start with the family. I hope our parents continue to teach us to love our countries and then to identify ourselves as Africans. You know, we are everywhere except where we're supposed to be. Like, we love other countries more than our countries. And when I talk to my fellow young men, I'm like, the challenge I have with the African story is no one wants to say that Mama Salon with the leadership, we have a 97% coverage in immunization. Everyone tells our story wrong. And we are entitled as the youth to tell our story right. That as long as we have corruption, we have poor education, unemployment, but at least we have got immunization right. So that is a responsibility for us. And this call is all of us in this room. When we go back, I take it as I'm the light of Africa, and I should tell our story right. And we have the capacity to solve our problems. I was inspired by what she has done. So we are here. Please support us. The leadership has been very, very supportive, especially of the Siravax. We are landing the first boat, solar-powered boat, in the riverine areas. And that shows that the leadership can support if only we start believing in ourselves. But if we don't believe in ourselves, we need to call expatriates from China to come and build our own stuff. So we start by now to say we want to locally own our health system, capacitate it, and locally participate at every level to build it better.
Thank you so much for that. Concern, statements to the panel.
I'm sorry. Good afternoon again, everyone. Yeah, so thank you very much to all of the panelists for a very, very invaluable discussion. One thing I would like to add specifically, and it's one that's very close to my heart, is geriatric mental health. It's one that we don't talk about a lot, but it's a very important one because I've seen in many instances where they've been misdiagnosed. And so it's very, very important. I know we don't have a lot of elderly people, but sadly also, as a country, we do not have a geriatrician. I'm lucky enough to have a training in geriatrics at the University of Toronto, but that is it. But so specifically, in geriatrics population, as far as mental health is related, we see a lot of cases of delirium, acute psychosis, and then Alzheimer's, like memory issues. And I want to talk about delirium just very briefly. So what happened, most of the time, even in our neighborhood, households, sometimes and most times in the hospitals, you see an elderly person, they just acutely became confused. Acute confusion, and then in some cases you see them like they are acting like as if they are crazy, like acute psychosis. 90% of the time is because of their medications. So as clinicians, let's please take the time when we examine an elderly. Let's don't just the same way we do for kids. When we we have a focused examination for kids, focusing on the areas and things that we know is common to them. So does adolescents. When we ask them questions, and we have a specific screening questioning targeted for adolescents, let's do the same for geriatrics. At every point of care, geriatrics population, let's make sure we can at least at the very minimum screen them for memory issues. And this, sometimes it takes like less than a minute right now, evidently. But I think another area also that we rarely talked about is pediatric mental health, one that's very close to my heart. I'm blessed to have Dr. Nelly Bell as my mentor when I just came to Africa. But so what we do as clinicians, we most of the time here in Sierra Leone, we don't screen the child for development. We actually have assessment, developmental milestones. Very, very important. And that's Very rarely done. We do that at the mobile health clinic, and there are so many diagnoses that we've made that are in the area of mental health, specifically things like ADHD, hyperactive attention deficit disorder, and as well as autism spectrum disorder, right? These are all things we can catch by just very, very simple questioning. So let's focus in the area of pediatric mental health as well as geriatric mental health. And I want to add something to the chronic diseases, like the non-communicable diseases. So over the past 3 years, since the launch of the mobile health clinic, we've seen over 50,000 Sierra Leoneans. And between the ages of 49 up.
Sir? Thank you very much, Emmanuel. You know, the good news about being an African is that we are all community oriented. You know, I've been 20 years in Switzerland. Nobody talks to you. You can spend 2 weeks without talking to anybody. Everything is automated in machines, etc. People die in their houses. Nobody cares for about a whole year or two because that oriented way of for people. So that's our greatest strength in Africa, and that's what I'll be working all over Sub-Saharan Africa, running mobile clinics, and that's what I leverage upon. We care for another. So if you go to those communities, you empower them, you increase their health-seeking behavior, you increase their health awareness. Trust me, we are going to win a whole lot, and that's why I'm a big fan of the out clinics. Now we have the in-English clinics, by the way, which is very, very important that the hunter can become a hunted if we don't care. So we are working on that very well as a ministry. Thank you, Dr. Nedibe, for that. But other community outreach, going beyond where the normal healthcare distance does it stop, cannot go. And empowering the community to take their health in their hands. This is what we at the Ministry of Health we are doing in Sierra Leone, a small country, who will be the Athens of healthcare system in West Africa. That's therefore the bosses. There are before we have seen the potential, the excellency, the president himself declared for those 4 bosses. So we are having the good potential to increase it to make sure we access all the communities and leverage upon that knowledge-seeking behavior from them. Then you can drive them to the local healthcare delivery system where they know that they are hypertensive. There's somebody who cares about them. We send out all the channels of healthcare delivery. I think that. Thank you.
Thank you. Thank you so much, Mr. Minister. Now we are going to do the vote of thanks. Madam Finda, I can never pronounce your last name right.
Good afternoon, good afternoon. Thank you so much for spending your afternoon with us. I'm going to make this quick and sweet so everybody can go home and enjoy whatever is left of the holiday. Thank you to everyone in here. A big thank you to Deputy Minister for spending half your day with us, including yesterday evening. Dr. Bell, you've always been there for us from our first symposium we did. You've always supported us. You've always given us information. Thank you, thank you, thank you. We definitely appreciate you mentioning the impact of addiction and chronic diseases, the impact they have on the pediatric population. We know that overseas and we're seeing it in Freetown, so thank you for that. Thank you, Dr. Bai. I think Dr. Pierre can finally sleep at night that his young doctors are taking over the baton. You did a fantastic job. And I think you guys are going to take the ball and roll with it. We can finally sleep at night peacefully. The next generation is coming up. Angela, you might be at work now. Thank you for a wonderful presentation. We're always looking forward to what you have to say. Thank you to the Symposium group, Dr. Cocker. You presented last year, you got all our attention with Kush. We had Kush in the state, but one thing most of the states did was ban it. So nobody has it, they can sell it, they can buy it. But you educated us last year, that's why we keep coming back for more information. We want to join and help, but tell us what we can do, educate us on what they're using Kush for. Ami, thanks for basically telling us mental health is just a chronic disease like hypertension or diabetes. So we, the family members, need to treat it as such and take all the stigmas away from it. And Dr. Sanor, as usual, you're always doing a fantastic job with pediatric. Thank you for your service. We appreciate it. our guests, especially the big team from Maryland, Washington, D.C. group. Thank you for coming to support Haja Kadi and all our family and friends. But first and foremost, Mrs. Spear and the Beaumont Hope Clinic. They're the reason we have such a wonderful food. They fed us today. Thank you, thank you. Thank you for letting Dr. Pierre do what he's doing. I know without your support, he wouldn't be here. We appreciate you. We don't want to take it for granted. Thank you, everyone, for coming, all our family and friends. Auntie Flo, Uncle Kelly, and all the others. Thank you so much. We appreciate you, and we'll see you again next year. Oh, group, come up for a picture. All else, Sierra Leone group.
Before everyone moves around, please, is the photographer still here? Can you please take a picture of the panel table? Then after that, Healthcare Australians membership with the panel. Then next will be pictures with the audience. So I don't know if you want to sit and take your pictures or stand the panel, take a picture of the panel.